Now allow me to introduce the second presenter today, my dear friend and colleague, Dr. Khadija. She's a consultant pediatric endocrinologist in King Hamad American Mission Hospital of Bahrain, and today she will be presenting congenital adrenal hyperplasia. Welcome, Dr. Khadija.
Thank you, Dr. Fatma. Good afternoon, everyone. I'll talk today about congenital adrenal hyperplasia. I try to simplify it as much as I can because it's one of the topics that most of the time my residents or medical students say it's difficult. I have nothing to disclose, and this is my outline. So we, as a human, have two adrenal glands, and it consists of adrenal cortex and medulla. The adrenal cortex has three layers: the capsule, the zona glomerulata, zona fasciculata, and reticularis. And these layers, each layer responsible to produce hormones, like the mineralocorticoids in the zona glomerulata, and glucocorticoid in fasciculata, and it is the biggest one, consists of 75%. And reticularis is the one responsible to produce the androgens, and the medulla is the one produce the catecholamines. These definitive zones actually enlarge, but two of the adult zones, glomerulosa and fasciculata, are not fully differentiated until about 3 years of age. And the reticularis may not be fully differentiated till about 15 years of age during the puberty. What control the production of the adrenal gland is the higher centers, the hypothalamus and the pituitary through the ACTH, producing the cortisol, and it gives a positive feedback to the higher centers. In order to understand the congenital adrenal hyperplasia, which is caused by enzymes deficiency, we have to understand, or at least to know, this pathway. I don't know if there is a pointer. I always like to use the pointer. Do you have? Okay. So we can see here the main, These hormones come from cholesterol, and we have three pathways. One pathway to produce the aldosterone, and the other to produce the cortisol, and the third one from the reticularis to produce the testosterone. If you want to talk about ambiguous genitalia, there are so many causes for ambiguous genitalia. Congenital adrenal hyperplasia, just one cause of ambiguous genitalia. We'll focus on 5 enzymes deficiencies and try to see what will happen if there is a deficiencies in those enzymes. The main enzymes will be the dismolase here, the blockage here, deficiency here. We have 3-beta hydroxysteroid dehydrogenase in the 3 lines, 17-alpha, 21 is the most common in 2 pathways, 2 lines, and 11-beta. The clinical manifestation of any child with congenital adrenal hyperplasia depends on the degree of cortisol deficiency, aldosterone deficiencies or excess, and the androgens level, whether increase or decrease. And these manifestations reflect the accumulation of the precursor, which, if present in supraphysiologic concentration, can cause hypertension or virilization. Like in case if there is decreased cortisol biosynthesis, the symptoms can be anorexia, poor weight gain, fatigue, vomiting, weakness, and hypoglycemia. Increased adrenal androgen can cause virilization in female. Decreased mineralocorticoid leads to dehydration, hyponatremia, and hyperkalemia. These are the major enzymes that I showed in the previously. I will start with the 2022 dismolase deficiency. It calls the STAR enzymes, and it is this one. So can we predict if there is no dismolase, what can we have in a child? What can he present with? Any idea? There is no dysmolase. So the 3 pathway will be shut down. Clear? No aldosterone, so we will have salt wasting, hyponatremia, hyperkalemia, with low cortisol, and the androgens will be low, testosterone will be low. So if he's a male, he'll present with under-virilized male or ambiguous genitalia. Female might not be affected her genitalia. Is it clear? It's very, very, very rare, and it's mainly in Japanese. It's caused by a mutation in the gene. I will not go through. As I said, yeah, one important point, because if this one deficient, the cholesterol will be in excess. So the adrenal gland will be huge, not only hyperplasia, will be very huge and can be seen radiologically because of accumulation of cholesterol. It's called lipoid as well. It can be presented, as mentioned, with salt-losing crisis and ambiguous genitalia in male patient because no androgens. The lab can show low cortisol, low aldosterone, low androgen, decrease or absent response to ACTH stimulation test, increase plasma renin, and as I said, massive adrenal enlargement by imaging studies. The second one, which is the most common, due to 21-hydroxylase deficiency. Where is the 21-hydroxylase deficiency? It is in the pathway of production of aldosterone and cortisol. So if we can think of it, if there is no aldosterone, we will have salt wasting. If no cortisol, low cortisol, and adrenal insufficiency, what will happen? The pathway will go towards the androgen and produce more testosterone. So if she is a female, will be virilized, will presented with ambiguous genitalia, similar to male. And if he is a male, he might be missed during, after birth. This is, as I said, is the commonest, around 90% of CAH. And as mentioned, decrease cortisol, aldosterone. So here, if the 17 hydroxyprogesterone will be high. This is the precursor, as this is the one that we measure during the screening for a newborn screening to see if it is high or not. There is a phenotype spectrum because this deficiency it's not absolute and 100%. So some cases they have just the cortisol, but the aldosterone is normal, and they can present it later, not early as a neonate. Who presented early as a neonate, we call it the classic, can be newborn, in a newborn, can be presented at the 2nd week, because still the mother give the child some aldosterone and there is no salt wasting, unless if she is a female and presented with ambiguous genitalia, can be detected immediately after birth, salt loss and failure to thrive. Simple virilizing present in a younger child between 2 to 6 years of age with precocious puberty. In non-classic type, present as adolescent, an adult female can come with hirsutism, irregular menses, and infertility. And here is the genitalia. See this one, it's like a complete male genitalia. She is a 46XX with a 21, but we can see in the scrotum is empty. Other can present with partial. So we have a scale to classify the genitalia. We call it the Brader scale. We have the typical female, and here is a typical male, and the scale consists of 5 stages. The first stage is just a clitoral hypertrophy, and the 5 stage, it's like complete masculinization. It looks like a male genitalia, but without testis. So we use this to describe the genitalia. It happens early, the exposure. Why we have ambiguous genitalia? Because it happens early exposure during the intrauterine at early as 8 to 10 weeks, because the androgens will be high in the fetus, especially if she is a female, which presents with ambiguous genitalia. Okay. Laboratory finding in salt wasting, hyponatremia, hyperkalemia, acidosis, hypoglycemia, 17-OHP will be high, cortisol low, aldosterone and testosterone are elevated in affected female, androstenedione and testosterone are elevated, androgen, ACTH is high, high renin level with low level of aldosterone. I will go to the next, it's 11-beta, hydroxysteroid deficiency. It is just below the 21. So we expect to have similar picture, supposed to be exactly similar picture. But do you know what is the main difference between these two enzymes, deficiency 21 and 11-beta? They're supposed to be the same, لا؟ لأن both pathway deficient, the androgen will be high. But there is one important thing. We can differentiate between both. So what? It will compensate, it has high mineralocorticoid effects, so it will work like aldosterone, so there will be hypertension and hypernatremia. Yes, excellent. This one, 11-deoxycorticoid. So they are exactly same, aldosterone low, cortisol is low, and the testosterone will be high because the pathway will be there. But due to the deoxycorticosteroid or the DOCA, this is very, very strong mineralocorticoid, so we will not have the signs of salt wasting. It is account for 5 to 10% of the cases, as I mentioned, will be hypertension, salt retention, hypokalemic alkalosis. This is the one. The last one is a 3-beta. 3-beta hydroxysteroid dehydrogenase. It is in the 3 pathway. So what will we have? Salt wasting because there is no aldosterone, no cortisol, testosterone is low or androgens is low. So, but, you know, we will have DHEAS, which is androgen, will be high. This androgen is not strong enough like testosterone in male, so we will have undervirilized male, ambiguous genitalia in male, and it will be high for a female, so we will have ambiguous genitalia in female. Is it clear? Yes. So both male and female can be presented with ambiguous genitalia. Salt losing a crisis, okay. It can be missed because sometimes we see this pathway, but it is not 100%. Sometimes there is like, you know what, some diseases just genetically diagnosed. The picture will not be full. Either there is a backdoor pathway for these hormones or it's a partial deficiency, not absolute. Not all the pictures can be typical as the textbook. It can be missing a female and presented with hirsutism, irregular menses at adulthood. These are the labs. The last one is 17-hydroxylase deficiency, which is here. So this one also, the aldosterone pathway will be complete and all will go to aldosterone pathway. So we will have high aldosterone, hypertension, hypernatremia, low cortisol and low androgen. Low androgen will give us, or low testosterone, undervirilized male and normal female genitalia. So now we have 2 hypertension, 17-alpha and the 11-beta. This can be presented, female usually are diagnosed upon presentation of delayed puberty or lack of menses. Males can go undiagnosed until puberty. These boys usually raised as a female and presented to an endocrinologist for evaluation of lack of secondary sexual characteristics. Diagnosis may be suspected earlier in an infant if there is an ambiguous genitalia or palpable gonads, palpable testis. It's like a female genitalia with testis. And these are the labs that will be seen. The labs is all increase the precursors of the, and low of the final, So how can we diagnose? I know I said in some of the slides, but the diagnosis can be prenatal if there is a suspected child. The next child, if the mother is pregnant, will look for the chorionic venous sampling in the first trimester between 9 to 10 weeks, or amniocentesis in the second trimester. By this way, we can determine the genotype of the fetus and the sex of the fetus. This is usually we use because of the common type is a 21. So if the fetus is a female, better to give the mother dexamethasone to suppress her own ACTH, that she will not have ambiguous genitalia. If he's a male, no need to give. So prenatal diagnosis and postnatal newborn screening. It's done in Bahrain in all the government and private hospitals. They use the 17-OHB because the most common type, as I said, 21 by Heilbroek, and potentially affected infants when it is high. We call them to come and we repeat the test. And the level usually, if it is above 100 nanomole or more than 3,300 nanogram per deciliter is diagnostic. And there is a level lower than that because we have different types, like the classic and the non-classic. It can be normal or a level in between, also in a carrier. They don't have the disease, just carry the disease. And these are the level. I saw it different in another place. The normal, less than 9 nanomole. The carrier or heterozygous between 9 and 45 nanomole. In non-classic between 45 to 300 nanomole, and more than 300 classic CAH. And also in the investigation to done electrolyte, glucose, karyotyping, especially in the newborn, we want to, if there is an ambiguous genitalia, karyotyping, and ultrasound in the pelvis, and surgical evaluation is very important. What is the treatment to be used? And do we have to treat? Yes, it's a must to treat congenital adrenal hyperplasia because our goal in treatment to achieve normal growth, normal bone maturation. It affects the timing of puberty, give us good cognitive development, especially those who present with a crisis and hypoglycemia. It can affect their cognitive development. It's important for self-esteem and the quality of life. Okay, and it can prevent the long-term complication like testicular adrenal rest tumor. Those who are under-treated can have this. It's not a malignant, but a testicular tumors happen because of the high ACTH in the testis. It can cause infertility if not treated, and adrenal crisis, which can lead to sudden death. So how can we treat the adrenal crisis? If a child presents with adrenal crisis, to all children to measure the blood glucose, electrolyte to check if there is hyperkalemia and hyponatremia, blood gas to look for acidosis. Those with first presentation, usually at 2 weeks of life, and it is not non-case of anything, if there is a suspicion, to do the further investigation before giving him the cortisol, before giving him the hydrocortisone. Check the cortisol, ACTH, 17-OHB, aldosterone, renin if possible, but the major thing to check the cortisol, ACTH, and 17-OHB. And then to start to give the patient, if he is in a crisis, the steroid stress doses. And the stress dose we calculated by 100 milligram per meter square as a start dose, and then we give a Q6 hourly. We have the doses, depends on the age of the child. And once the child is stable, we will switch to the triple dose of the hydrocortisone and then to the maintenance doses. This is regarding the hydrocortisone. IV fluid is very important if the patient presented on shock or severe dehydration. Bolus of normal saline to be given and reassess the response, and can be repeated also. And then to be given the deficit and maintenance fluid over 24 hours of normal saline and dextrose. Hypoglycemia, it's seen mainly in infants and small children. On a crisis, bolus of 10% glucose, 2 to 5 ml per kg to be given IV. If there is hyperkalemia, do we have to treat hyperkalemia in a crisis? Usually not. It will be normalized by itself with the fluid and hydrocortisone, unless if it is really very high, like above 7, or there is ECG changes, then follow the protocol of treating the hyperkalemia with salbutamol, insulin, and glucose. Okay, so the treatment basically will be hydrocortisone. We are giving in supraphysiological dose, suppressed dose to suppress the ACTH, 10 to 15 milligram per meter square per day. Fludrocortisone, 50 to 100 microgram per day. We can go, especially the newborn, sometimes they are resistant, so we can go with higher doses. And to give newborn sodium chloride sometimes, 5 millimole per kg per day, because sometimes it's very difficult to normalize the sodium. After that in childhood, they will not need the sodium chloride. Even after the neonatal period, they will not need the sodium chloride, only fludrocortisone and hydrocortisone. We can give hydrocortisone, prednisolone, and dexamethasone, but we always prefer to give the hydrocortisone in children rather than prednisolone and dexamethasone can be given in adult. What are the practical tips in treating? Hydrocortisone administered in tablet form, which can be crushed and given immediately to the patient, mixed with milk or water. Better to have a pre-prepared formula, because the suspended liquid, it might not be even in distribution. Well, other potent form, as I mentioned, like prednisolone and dexamethasone, are not recommended in children because there is a potential concern of linear growth suppression associated with longer acting and more potent glucocorticoids formulation. We can give them post-pubertal. Very, very important for any child that we explain to the parents the sick day rules in case of there is moderate stress, severe stress, to double and triple the doses. And if there is a severe stress like a trauma, to give the stress dose. There is an injection should be given to the children at home. Unfortunately, we are not doing this practice in Bahrain. To be used during the stress, like sometimes the patient might be in shock, hypoglycemic, and to be taken to the hospital immediately, or especially those patients if you cannot give oral medication due to vomiting. Now, if you under-treat, it's very important to treat properly the child. Under-treatment, as mentioned earlier, can cause death with salt-losing type, can cause virilization, advanced skeletal maturation, GnRH-dependent precocious puberty, end up with adult short stature, hirsutism, oligo or amenorrhea, and infertility. On the other hand, over-treatment can cause short stature, obesity, and iatrogenic Cushing syndrome. Medical treatment and surgical treatment. If there is ambiguous genitalia, usually the surgeon do the correction. It might be more than one time correction, but they start usually between 6 to 12 months of age. Follow-up. Follow-up need to be weekly in a neonatal period, 1 to 3 monthly during infancy, 4 to 6 months thereafter. Electrolytes are not necessarily if the child is thriving well and asymptomatic. We can do 17-OHP and androgen twice per year, bone age every year. And in every visit, it's very important to check the height, weight, BMI, blood pressure, and closely monitor the linear growth, weight gain, pubertal development, and skeletal maturation. Don't forget to give your patient alert card or bracelet that when he presents to the hospital or any place, they know that he had congenital adrenal hyperplasia. We almost finished. This case need multidisciplinary team. It's not an easy to deal with alone as an endocrinologist, especially in the beginning. If the mother knows that her child has ambiguous genitalia, is very difficult. So we need psychologist, radiologist, genetics, surgeon. It's a multidisciplinary teamwork. So in summary, I finish almost. To make it simplify, it's mainly 5 enzymes affecting deficiency in the congenital adrenal hyperplasia. Some cause hypotension, like 20-22 dysmolase, 21-hydroxylase, and 3-beta. Other can cause hypertension too, 17-hydroxylase deficiency and 11-beta, due to the precursor, which is one is deoxycorticosteroid, and the other one because the pathway is only aldosterone. 17, the pathway is only aldosterone, we have high aldosterone. And in male and female, the ambiguous genitalia in male, when there is less androgen. If the androgen is high, we might not have, he can be missed. There is less androgen, he might have just hypospadias or, under-virilized male. It's mainly in 17-hydroxylase deficiency, which affected the androgen pathway, 3-beta, and 20-22 dysmolase. Female is the opposite, when the androgens are high, so the pathway for high androgen, 21-hydroxylase and 11-beta hydroxylase deficiency. I think done before the time. Thank you so much.
Thank you, Dr. Khadija, for presenting this important topic.